All right, well, good afternoon, everyone, and thanks again so much for your patience as we get going here. We are having some audio troubles, but I think we're all squared away and we'll get right into it. So good afternoon, the Association for Professionals in Infection Control and Epidemiology, Great Lakes chapter, in partnership with the Michigan Vascular Access Network, is pleased to offer today's session titled Ultrasound Guided Peripheral IV Insertion. Do you contaminate when you are inserting? My name is Kelsey Ostergren, and I am joined by Chow Nguyen, and we serve as the education co-chairs for APIC Great Lakes. And we have had the great pleasure of collaborating with Matt Gibson from MyVan to put on today's event, which has been sponsored by Civco. The presentation is being recorded, and the slides will be made available following, as will the recording, and will be posted on our YouTube channel. And so we want to know who is on the line today. So if you can provide your name and email address in chat, we want to make sure we capture everybody who has joined so that we can send out that slide deck and presentation recording following our session today. And I'm sure you saw CE credits are also available for today's session. So email addresses also will help us to disseminate the post-event evaluation link so that you can receive your credits. So just to confirm, name and email address in the chat would be great, so we make sure you're accounted for and can follow up with CE information. All right, so with that, I am pleased to introduce our speaker for today, Matt Gibson. Since 1993, Matt has worked in an area of nursing where vascular access was primary and essential skill. Emergency department, ICU and telemetry, house supervisor, home infusion, and long-term care vascular access teams. Soon he realized his passion for vascular access and decided to seek out more opportunities. And over the last decade, Matt has served national and local vascular access organizations, assumed leadership positions in multiple committees as resident advisor, and is a published author in the area of vascular access. Matt currently works with multiple organizations as a vascular access consultant and speaker, and he is a certified registered nurse infusion, vascular access board certified, and certified PIC ultrasound user. Matt is also the CEO of Vascular Access Consulting, as well as the current president and founder of the Kentucky, Indiana Vascular Access Network. So with that, Matt, welcome. We are so glad to have you, and I will turn the floor. And Matt, you are still muted.
Okay, let me start again. How's that? Can you hear me now?
Yes, we can.
All right, great. Well, thanks so much for inviting me to do this presentation. I'm actually my phone is getting blown up with people not being able to get on. I'm not sure what's going on, but if you know of if anybody that's on this webinar and you know a friend that's trying to get on, send them the link because I'm not going to be able to address the phone calls coming in. So I really am excited about APIC Great Lakes and the MyVan organization collaboration together. It's really awesome. And man, this has been such a great, we had a huge number of people sign up. So it's very great in my opinion. Let me share my screen here and we'll see if we can get the presentation up. And this should be a slideshow here. Oops, no, wrong. No, stand by from beginning. All right. Now, you guys should be seeing my screen. Can I get a yeah, we can see it?
Yep, Matt, we can see it. All looks good.
Fantastic. So ultrasound guided peripheral IV insertions. Do you contaminate when you're inserting? And I wrote this program because people just aren't aware, honestly, of what touch contamination is during the procedure. It's very common. Honestly, it's the rarity that I don't see some type of contamination whenever I'm out doing education and whatnot. So that's where this is coming from. A lot of this applies to peripheral IV insertion in addition to ultrasound guided, because obviously there's certain things that we do. We use an ultrasound, but this is, standard contamination during peripheral IV as well. Excuse me. So my disclosures, and Kelsey, thank you for thanking Civco. Anybody that's done any kind of work like this, these presentations take a lot of time and effort to put together. We appreciate Civco and helping to support that. I do work with a lot of people doing education, writing education. I'm a consultant on some research projects and whatnot. My personal and professional mission statement is to advance the practice of vascular access and eliminate complications, which the majority of the folks I'm talking to today are infection preventionists. Peripheral IV infections is a problem. Whether we want to acknowledge it, recognize it, or do anything about it, it's there and it's real. So here are some of my objectives. I want to discuss aseptic non-touch technique. Now, I don't know how much of this, how many people out there have actually heard about this, but this is something that is coming on strong globally, and it's a really great framework. I want to identify some contamination events. Closing some applications. Okay. Are you guys still hearing me? I got a notification that the audio wasn't good.
Yep, we can still hear you.
Okay, good. So if I start to break up or something, then please holler. Contamination is really prevalent in peripheral IV. We're going to take ANTT and apply it to ultrasound insertions, and we're going to look at probes and gel and as a source of contamination, and then we're going to talk about some insertion techniques to help eliminate that risk. Peripheral IVs are the most frequently placed invasive device in the world. The literature tells us up to 90% of patients have a peripheral IV in the hospital. 100% of my patients have vascular access devices. With 350 million peripheral catheters sold every year in the United States, it is shocking that the failure rate is 50, 60, some sources even say almost up to 70% of failure before completion of therapy. And that alone should be enough for us to say, we have a problem here. And the problem is getting national recognition from the Emergency Center Research Institute, ECRI, which is the most trusted voice in healthcare for patient safety. The peripheral IV harm has made the top 10 list in 2019 and 2021. So this is really becoming more on the forefront. Peripheral IV bloodstream infections, when we look at this and we just look at Staph aureus infections, we see a large number of Staph aureus bloodstream infections coming from peripheral IVs. And as we look at the comparison between peripheral IVs and central, everybody's concerned about central lines. We need to, absolutely. But whenever you look at the numbers, and this is just of Staph aureus infection, the numbers of peripheral IV infections sometimes outweigh the number of CVC bloodstream infections. It's really shocking, and it's a huge concern. In addition to the infection, difficult venous access is a real common occurrence with peripheral IV insertions. How to manage these patients, depending on the source, 1 in 10 patients have difficult access, 1 in 3, every other patient, depending on your population, your acuity of the patient that you're taking care of. But I think that we can agree that difficult venous access is a problem. One of the solutions is ultrasound guided peripheral IVs. This is a common occurrence that you see on a difficult venous access patient. They are pin cushions. they just get stuck over and over and over again. And in the process of placing these, this is something you'll commonly see. Like whenever you look at this, look at the number. I'm going to point these out. Peripheral IV. Obviously, that is a failure. It has blood in it. Peripheral IV, peripheral IV. So does this picture look like any type of standardization? Is this a systematic approach to peripheral IVs? I can say no. Like, and this is what you see. This is what, as a vascular access clinician, I'm called to. And when we have unsuccessfuls, and when I visit my ERs, this is what I commonly see. Okay, so it really isn't okay to place a peripheral IV with an ungloved hand, and it's definitely not okay to repalpate the site with a gloveless finger. This is what I walked into. The setup before with 3 peripheral IV attempts. I come into the room and I say, I have my ultrasound. I say, hey, we're here. She's like, oh, no, I think I feel one over here. I'm gonna give this a shot. And so this is what she proceeded to do. Now I'm watching this very carefully, and she goes, oh, I got it. She got blood return, and this is how much catheter was left. I'm going to talk about this in more detail later, but this is a very small amount of catheter that is actually in that vein. and this is something that happens oftentimes. We use too short of veins, whether we're using ultrasound or not, or too short of catheters rather, and whether we're using ultrasound or not. But we have to have the proper equipment. But what we're really looking for is a standard approach, a standard insertion. We want a big fat juicy vein out of areas of flexion on a flat surface that we can secure properly. And you can achieve this with many times with ultrasound when you can't with a traditional approach. Now, I want everybody to go to their little chat box, and I've got a polling question. I don't think we were set up to do polls here, but I want you to answer this question and just type this into the chat. This is such an interesting question, and it is so varied. How do you describe the technique of ultrasound-guided peripheral IV insertion? Is this a clean procedure? Is this a sterile or not sterile or non-sterile? Or is this an aseptic procedure? So play along with me here, you guys. Go to your chat box, enter in what your answer is. I'm very curious. And Chelsea, after the next slide, if you could just look at the chat, give us a breakdown of what people have said, because that's definitely going to reveal. So I'm taking this one step farther, and I'm going to when I have conversations with people about these terminologies, I am telling you, some of the smartest people I know, the people I respect, absolutely cannot agree upon this question. Absolutely cannot agree upon it. And so whenever I was like, you know what? And me and my simple Kentucky, country boy self, I need a little help here, because my definition is not what everybody else's definition is, so to speak. So I looked up in a medical dictionary what the definitions. Clean is free from contamination or disease. I like that. Like, free from contamination as far as a technique goes, that's good. Like, I like that. We definitely want clean skin, because we can't sterilize skin. So that's a great, a clean skin. Non-sterile. This is not free from germs or microorganisms. I'm stating the obvious here, but the skin is never going to be sterile. It's never going to be sterile. Aseptic is free or freed from pathogenic microorganisms. Now we're getting a little bit more specific. And when you look to the Association for Vascular Access, they go one step further with this definition. It is the absence of pathogenic organisms in sufficient quantity to cause an infection. I like that. Like, that makes sense to me. It's quantified and it makes sense. So basically, you know, an aseptic technique, we're assuming we've freed the skin good enough of pathogenic living organisms to prevent an infection. Sterile. This is free from living microorganisms, especially pathogenic. And one step farther, they use a synonym. What is this? Aseptic. Here lies the confusion, because clean is free from contamination. Aseptic is freed from pathogenic microorganisms in sufficient quantity, and sterile is free from all living microorganisms, and they call it aseptic. And so the synonym for sterile is aseptic. But you hear people say it's not sterile procedure, it's aseptic, which means, what is it? It's the same word. So you have this debate. So I'm curious, Kelsey, did you come up with any numbers for me?
I sure did. So we
have?
had 18 responses saying D, or aseptic. We had one response that said clean and 3 that said sterile. So really heavy on the D.
Yeah, which is great, aseptic. But when we get into that definition and we understand what people mean by aseptic, some people mean clean for aseptic, and some people mean sterile. And this is exactly what I'm talking about. We really just can't agree upon what this means. Enter ANTT, aseptic non-touch technique. This is a framework for invasive procedures. This is global, you guys. This has been around for 20 years. It's come to the United States. It's now integrated in the standards of practice in 2021. And it is really, really what we need to clear up the mucky waters of aseptic, clean, and sterile. The principles, they have safeguards and principles for ANTT. And the safeguards is basic infective precautions. Wash your hands. Here is an important aspect of this. Identify key sites and key parts. And here's another thing that people are not going to agree upon. Absolutely not going to agree upon what all of these particular key parts are. Another part of this is non-touch technique. You know, once you've identified your key sites and key parts, you can't touch them. You don't touch it. No touchy on the key sites and the key parts. And we have to maintain and manage that aseptic field. So the principles are, let's protect the patients from infection. We need to protect the key sites, and we protect the patient from infection by protecting the key sites and key parts. And it needs to be efficient and not too complicated, you know, as well as safe. We need to be efficient, which this technique breaks it down into standard, which is an uncomplicated invasive procedure, versus a surgical, which is much more complicated, where you're implanting things, you're removing things, you're, you know, doing surgery. You know, so these are some concept principles that we use. We also want to standardize. You know, we want to make it simple. We want to make it efficient. We want to standardize it, and we want to make sure everybody is trained properly. We need, you know, appropriate environment, the appropriate equipment, the appropriate training in order to everybody be on the same page with this and systematically approach ultrasound guided peripheral IV insertion in a standardized method. There are a few more terms that ANT goes into. It's a general aseptic field. This is a non-sterile field. It could be a disposable tray, could be a disinfected table, appropriately disinfected table. It could also be this barrier that we put down. That's your general, it's just a clean space to work. That's all it is. Critical microaseptic fields. This is a mouthful. To me, it's just like, can you come up with something a little simpler, a little catchier? But honestly, this is what it is. This is a sterile field that is critical to prevent the risk of infection. And these are to protect our key sites. So the critical microaseptic field is going to be the caps for all of these key parts. The cover for the catheter, all of these parts, if they get contaminated, can increase the likeliness of an infection. So all the key parts are those parts that follow the fluid pathway or that are placed in the blood. You know, the catheter lumen, the hub. So the little hub, and I'll show you this in a picture in a minute. The backside of the catheter that you're going to push off needs to be protected. The tip of the syringe, the needless connector septum, even the probe foot would be considered a key part because it potentially is going to touch the catheter itself. So key site. Now, this is such an interesting concept to me. What is a key site for you guys? You know, what do you consider when placing a peripheral IV a key site? Is it that 1 millimeter dot that you stick the needle through? Is that it? Or maybe, oh, it's just right around the insertion site, you know, so I can palpate over upstream as long as I don't touch the site. Well, what is that site? Or are you considering everything that's going to be under the dressing a key site that if you contaminate will likely, you know, cause an infection? You know, we definitely in the central world, we consider everything under that dressing as a key site, so to speak. But if everything under the dressing is a key site, then you can't touch this part of the catheter, this spin nut, or this extension tubing with clean gloves and maintain an aseptic non-touch technique. You know, so this is something to really, really think about and define for your institution. A lot of, you know, this ANTT came out in the INS standards of practice. And what many people have done is they've just taken out clean or sterile, whatever their terminology was, and just inserted ANTT. Guys, that's not okay. There is a whole framework here that we have to observe if we're truly going to protect our patients. And that is identifying those key parts, identifying those key sites, and preventing the contamination through through compliance, observation, and whatnot. You know, it's not enough just to change the words. We have to change the practice. So the risk of contamination during insertions, why is this? You know, what happens? Well, you know what? This is a difficult venous access patient. They've probably been stuck multiple times. We're just trying to get the line in. And so we just aren't real aware of what we're touching and when we're touching it. You know, another failure comes with standardization. You know, everybody, it just does it a different way. You know, I mean, I've seen people, you see people throw all their supplies up on the belly of the patient or throw it up on the bed, and you know, there's blood and body fluids and whatnot, what have you, you know, that's present, and it's just too close. You know, we have to standardize this process. We need to use the standard supplies. Everybody do it in the same way. Make sure that we have the supplies. One of the common things with ultrasound is you run out of this, you run out of that, you don't have this. And so what are you reaching for? You're reaching for a substitute. If I don't have a sterile probe cover, oh, here's one on the shelf. It's not sterile, but it's a probe cover, so if you're standardized, to use a sterile probe cover, then substituting, a non-sterile, it throws off your standardization. Dr. Nancy Monroe did a survey on ultrasound guided peripheral IVs. And one of the questions were, do you use sterile gel? Because we're part of the discovery here is what people are doing and what works and what really doesn't. Now, the fact of the matter is we're not really collecting data on our outcomes, so we don't really know, what the results are, but we know what the risks are. So what she found during her survey was that, a little over half of the people were using sterile gel. And the gel can cause some problems. And the problem is with securement and adherence of the dressing. So for short peripheral catheters, many people don't use a securement device or some other method of securing the device other than the dressing. And so that becomes the sole modality of securing the device. But if you don't clean the gel off good enough, the dressing doesn't want to stick. Not only does the dressing not want to stick, but the gel residue is a breeding ground for bacteria. So, I'm in a hurry, I wipe it off, I slap the dressing on, say they're in ER, and then upstairs they go, and in transition, they pull a little bit on the tubing and the line's out. If it does stay down, 3 days later, this patient's in ICU, and they end up with a fever, and what's going on? Oh, we've got some breeding ground for bacteria right around the insertion site because we didn't quite get all the gel cleaned off of the insertion site. So other modes of contamination is the probe, not improper disinfection of the probe, touch contamination. I've talked about. I'm going to talk a whole lot more about this. I've got pictures and videos. Multi-use gel bottles. This is very common. People are using this, and these are going with the ultrasound machine in the COVID room, in the isolation room for this and that and everything else, and we're just tracking it all around, the hospital. And then if they're not using, another thing that they're using is just anything they can find. Well, dang, I'm out of gel, or I left my bottle in that other room. What do we got over here? So they're, trying to find something to use. It's all just a little bit crazy, honestly. Yeah, So here's an example of something I found just making rounds. This was sitting in the hallway, no one around, and I pull up to this ultrasound machine, and the jet or the probe cover is still on the probe, and a big streak of blood, is there present on the probe. So someone didn't clean the probe before or after the insertion. And we've got this sitting there out in the middle of the hallway, and it's just poor practice, just really poor practice. So I'm going to go through some pictures and some videos, and I want you to start training your eye for contamination. So here we have, take a look at this picture. So I'm going to describe what I see. One, I see that this site, it looks like to me this site's already been prepped. There's some tinting here, maybe going to be going into this AC here, or maybe in the upper arm. We've got a probe cover, maybe a sterile probe cover, maybe not, but we definitely know this is non-sterile gel. Take a look at this. This is something common that you will see. I hate to call ER out so much on this, but You see this common, this right here, common in ER. Depending on the extension tubing, some of those caps of those extension tubings are extremely difficult to remove. And so when you're one-handed, people loosen up the cap or just take it off. Another thing I see here is the 2x2s over here. So if we're going to use this to wipe gel off, this is on a table. Has the table been properly disinfected? Is this what they're using for their general aseptic field? Yeah, I don't know about that. But if they pick this up, potentially this is contaminated. They're going to rub it on their site to rub the gel off. Also, this site doesn't look like it's been prepped yet. So what about this CHG prep right here? Are we going to pick this up and go over here and scrub the site when it's been touching the table? I can tell you this. I was on the Vascular Access and Infusion Facebook page. It's a closed group. And I asked this very question: if you have a CHG prep that's on a table, will you pick it up and prep the site with it? And almost without failure, that everybody was like, no, that's contaminated. And I apologize for the blurry picture, but so I'm gonna help you point some stuff out here. You got two hands with gloves on them, but what's going on with the finger here? What's going on with the finger over here? You got a probe that has no probe cover on it. Whether we have sterile gel or not remains to be seen. However, they're getting ready to insert this catheter straight through that gel, so as they're scanning, if this isn't, whether this is sterile or not, it's become contaminated as soon as you apply that non-sterile probe to it. Oh, I love this picture. This is great. So this is a common occurrence here. You've got all this mess of gel all over the place. They've accessed the vein. You've got good blood return right here. You go to thread the catheter off, and you see this little tab right here. That's the push tab. That's what we push the catheter off with. That's what that is designed to do. But with the longer catheters and the deeper veins, we run out of finger. We don't have enough finger to thread the whole catheter. So what do? We reset, pull our finger back, and you can see this is the hub of the catheter, and that finger is just pushed right up onto that hub. That is touch contamination. This is probably one of the more common ways. If everybody does everything perfect, this is the way they contaminate. And it's solved by doing laying your probe down and threading it with the other hand with two fingers. Yes, I've seen people. Yes, I've done this. I'm in mobile vascular access. And I've been out in the field, not had all my supplies, and I certainly have done this. Do I recommend this? Is this a standard of care? Let's not do this. It's a sterile glove over a probe, and it just is messy. It's just messy and not necessary. So here you go. Watch this procedure. Oh yeah. I'm going to clean my finger off. That's going to kill all the germs. Then I'm going to palpate. I thought I felt it. Oh, better clean it one more time. I just picked the alcohol prep off of the table that I did not clean, and I reapplied, and there you go. I'm going right back to it. You will see this commonly with this finger pulled out. Now, obviously, I'm not using an ultrasound here, but I want you guys to understand, the bigger picture is contamination for all peripheral IV insertion, and this is very common. If you remember the picture in the very beginning where it just had 0.9 centimeters that was going to be dwelling inside the vein, this is the same girl. She switched hands, palpated with her non-gloved hand. You know, why not just, I mean, if you're going to palpate, why not use the glove hand? Like, why can't we do that? You know, but certainly, you know, is this exposing or contaminating the key site? Depends on how you, you know, define it, but still is not typically acceptable practice and would be considered contamination. Here's a video I'll let you watch, and then we'll comment. A couple of hints here. He's using non-sterile gloves, non-sterile gel, and non-sterile probe cover. Notice the movement back towards the catheter. Yes, he just ran the catheter over with the sterile probe cover or the non-sterile probe cover. And you did, in fact, see this correctly. He's got a 2.5-inch catheter that he put his finger on in the middle of the catheter to stabilize this insertion. This is a director. He is a smart man. He is a physician and had no clue that he had contaminated in any way during this procedure. This is why I say, you know, this is where this whole presentation comes from. Do you contaminate? We all say no, but I'd like to record, you know, I'd like to record more procedures. So once he gets the line in, so he picks up the 2x2 and he's cleaning the site off. He flips the 2x2 over and keeps on rubbing. Notice right here, we don't quite have all the gel off, but that's all right. We slap it on. He goes to take the extension tubing up, drops the needleless connector on the table, then picks it up with his non-sterile glove, grabs a hold of the end where the septum is. Wait for it. Yes, he connected the syringe without cleaning the septum. Like, this guy's, we're just trying to kill this guy. You know, we're just trying to kill him. Oh. Okay. All right. So you know, you saw that insertion. There was not thorough cleaning of the gel off of that insertion site. So let's talk more about gel. Gel is a dirty place. It's just dirty. It really is. Whenever you use multi-use bottles, you know, when we look back over the last 20 years, my goodness, there's article after article after article, even gel recalls from contamination before they ever get to the hospital. Like, this is something that we need to think about and consider, you know, what we're doing with this. You know, these are all, you know, evidence that shows, you know, we have a problem with contamination. So when we start looking at our standards and whatnot, and we're looking for direction about what to do, we look at there's a couple of different guidelines out there. If you don't have this, you know, and you want to approach your emergency department about improving care, this is a great document to help support your cause. This is from the American College of Emergency Room Physicians, and they say use sterile gel for percutaneous guided procedures. You know, so that would definitely include peripheral IVs. And they're also going to say use a single sterile gel packet, single use, you know, sterile gel. This is coming from the Emergency Room Physicians Association. My guess is that if you visit your ER, this is not well observed, and yet it's from you know, their group, the emergency group. Another document you can add to your arsenal is the Association for Vascular Access guidance document on ANTT. This really it takes ANTT and applies it to vascular access, and it's very, very, very helpful, and a published document that you can help support why you want to make this change. And lastly, the Infusion Standards of Practice now has this as their standardization way for placing devices. And if you're, use sterile single-use gel packets and a sterile probe cover, and make sure you disinfect before you use, just in case, and definitely after you use the probe. So can y'all hear me? I hear somebody.
We can still hear you.
Okay. All right, great. Getting to one of the last supporting documents, this comes from the American Institute of Ultrasound Medicine. And there's a couple of very interesting items here. First, they say, you know what? You need to be qualified and trained on the ultrasound machine. You gotta know how to use this thing. And what I'm saying is, if you can't identify a nerve bundle, if you can't identify an artery or the appropriate venous target, you don't need to be using an ultrasound. Like, stop. You need the training. You need the understanding of what you're seeing, or you're going to cause harm. Use equipment that was designed for the application. Okay, I saw somebody trying to use a bladder scanner. I'm like, what are you doing? Why are you using ultrasound? No. They also call out outlines of training for peripheral, and they call out peripheral IV specifically. They also call out sterile gel and sterile probe covers. They say clean or sterile gloves. And what is the most interesting thing here that I found with all of this, and the most surprising, is they say adequate catheter length. Now, these are not inserters. These are people that do gallbladder scans and scan your heart and scan this and scan everything. But they're calling out the catheter length. Like, this is so important. Now, I'm going to throw in here one other factor that we need to understand, and that's vein diameter. This is not from the AIUM people, but I have to, you can't talk about catheter length and vessel depth without talking about diameter, because they go hand in hand, and both of them are very, very important when we're placing peripheral IVs with ultrasound. And this, I'm going to get off on a little bit of a tangent. I'm getting into the weeds here just a little bit, you guys, but I want you to know, I want you to understand that this is a culture change that we need to push forward. Peripheral IVs, there's been some research that has shown that the angle of our tip of our catheter grossly impacts our outcome. And if you see this angle right here, this tip is pushing straight into that vein wall. And a simple flush, push-pause flush, can have enough shear stress to blow off the inner wall of that catheter. What we need is a catheter that's either floating in the center of the vein, which has to do with diameter and big enough vein. And if we don't have a big enough vein for that catheter to float in the middle, it needs to be parallel. And it all has to do with the length of catheter you're using and the depth of the vessel you're sticking. This is one of the most interesting studies that I've read, and it really speaks to why failures occur, honestly. This study was 62 catheters were monitored every day with an ultrasound until either failure occurred or the patient was completed therapy and was discharged and the line was DC'd. 87% of these catheters had some type of thrombosis at the insertion site around a pericatheter or proximal to the tip. 54 of these were symptomatic. So, we're talking about a third of them that were present. We didn't even know it. And what this study found was that the catheter diameter and the angle of the tip was significant factors in those in thrombophlebitis. We need a vein that is 3 times the size of the catheter that we're placing, and we need to place it parallel to the vein wall or floating inside the vein, and not at a tip angle of greater than 5 to 6 degrees. Does anybody know what 5 to 6 degrees is? Like, you can't look at it. It's hard to look at a protractor and go, well, that's about 6.2 degrees. It's just any kind of angle towards that vein wall pretty much is going to have a bad outcome. This was their conclusion. Catheter size relative to vein size is a modifiable factor that should be considered when inserting peripheral IV catheters. That is huge. Here's an example. If you're not used to looking at ultrasound, these 2 little dots are the catheter, 2 little dots, tiny vein, little bit bigger vein, big giant vein. This is what the benefit of ultrasound is. It's one of the things when we're using ultrasound, we can identify what the best vein to accommodate the catheter. And guess what? That's what's in the standard of practice. They don't get specific, but they do call out, we want to use the vein that best accommodates the catheter. If you're interested in any of these studies that support this, I have them. Please get a hold of me and I will facilitate the information so that you know. So let's think of this in an applicable fashion. Okay, a 20 gauge catheter is about 1.1 millimeter. Hang with me here, you guys. Hang with me. 1.1 millimeter catheter. So we're basically looking for a vein that's better than 3 millimeters in diameter, which when you palpate, you can palpate that vein and it has a nice bounce to it. So I asked a friend, I know a lot of people in vascular access, and one of the girls from Michigan, I consider this team a high functioning team. They place short peripheral catheters, PICC lines, midlines, central lines, and dialysis catheters. They're very versed in the standards of practice and very skilled at placing devices. So I asked her this. I said, hey, I want you to go, look at the next 3 patients that you would put a 20 gauge in, not using an ultrasound, just simply sticking the patient. They do a ton of lines without ultrasound. They're also a rapid response team, and this team, again, is very high functioning. And so, if they can place a line without an ultrasound, then they do. This is what she found, which was just fantastic. It just absolutely is fantastic. You can see these pictures are very hard to see, but there's a little shadow here, a little shadow here, little shadow here. And I said, okay, so these are all veins you would put a 20 gauge catheter in. Now measure them out and see what they show. 1.5 millimeters, 1.2 millimeters, 0.9 millimeters. Again, what's the size of a 20 gauge catheter? Probably the most commonly used catheter in the planet. It's 1.1. What size vein are we looking for that the studies say that we need? About 3 times that, 3.6 or 3.3 maybe, 3 to 3.5 millimeter. We are routinely placing peripheral catheters in too small of veins every day, all day long. So I know this was a little bit of a sidetrack and a little bit of a tangent, but I just can't talk about peripheral IV insertions without getting this in here. This is how we're going to change our outcomes. We have to make better choices on insertion. So let's get back to the workflow and talk about gel a little bit more. So when we are working with the ultrasound, we've got to assess. And this is commonly what you will see when somebody's assessing. A big gobbledygook of gel, scanning. And then I found my site. Okay, I found it. Now I need to prep the site and get ready. I'll let you watch this just a minute. I need to drink. Getting all my stuff ready. Go to put the tourniquet back on. Oh my God, it won't stay. Oh God, who put all this gel on here? Oh my God, this is so aggravating. Oh, I might as well just start all over again. So what do? You got to clean everything off. You got to retie the tourniquet. The whole time, everybody's laughing at you because they've done 3 more lines and they've just moved on. So here, this is part of the problem with gel. When you're scanning and you're trying to find a site, you have to use more gel, and it's just a big mess. And again, we talked about removing the gel from the site. I mean, it is a problem that the dressings won't stick, and we have to do a very thorough job of that. Also, we need to disinfect the probe, but we also need to clean the gel off of it, and sometimes on the little parts of the thing, it's hard to get off as well. So, obviously, this is something that we want to prevent. Is blood contamination. Hello, this is Matt Gibson. I'm here with some friends. We're going to do a toe-to-toe video, and we're looking at probe covers. One without gel and one with gel. I want to do a little demonstration with using a gel as probe cover. Ladies, are you ready? I'm going to give a countdown. 3, 2, 1, insert. So, if you ever wondered what vascular access clinicians do in their downtime, this is the crazy stuff we do. Now that we have the peripheral IV catheters in, we are going to do a time elapse of the cleanup and the dressing. So ladies, if you will, get your supplies ready. We're going to give a countdown, and they're going to dress the peripheral IV catheters in 3, 2, 1. This girl's got her dressing already on, and she just keeps on wiping. Keep on wiping. So I did call out and I said, hey, you got some more gel on that. You need to get all that gel off. That thing's not going to stick. So she just keeps on cleaning. Now watch this carefully when she pulls this border off. The doggone thing after all that, she still didn't get the gel off enough for the thing to stick properly. You see this, right around this edge, this is starting to peel up a little bit. On this one, it's consistently down around all of the margins of the catheter itself. And there you have it. this is what you typically will see, when you're trying to clean these sites up, and you have an extended period of time. So even say, a minute extra. If you're using gel and you do 30,000 lines a year with ultrasound, 3,000 minutes is about 50 hours, and that's somebody's vacation that they could have had in the time that you are cleaning gel. So and I've stopped using the word gelless, because I thought that sounded a little bit odd. So now I say gel free instead of jealous, because my Kentucky hillbilly is a little bit backwards, with that whole jealous thing. So here we go. This is a demonstration of how the difference would, placing this device. So a gel-free type of product. And there are a few of these on the market, that are somewhat similar. This one I found very easily to use. You got these little tabs you pull off, and then you spread this out. Notice there is no gel on the inside of that probe, so definitely makes it easy for cleanup. You're going to push it right down, and remember, I'm going to identify that probe foot is a key part. So I'm not going to take my clean gloves and run over top of that. Placing that stretched over that foot is perfect for a clear vision for the ultrasound screen. So some people say, well, oh Matt, why don't you just use a TSM? Well, when you look at the manufacturer's instruction for use, it says do not apply adhesive film such as Tegaderm to transducer lenses. Why is that? Because it can damage the lens. So when you look at this, this probe is hard plastic, but this foot is where the lens is. This is not hard plastic. And pulling these adhesive dressings off of this foot will over time degrade the foot, damage it, potentially crack. It's going to void your warranty, and then you're going to have a new probe. May not happen the one time that you use it, but if this is your standardization process, and you're putting, and you do a lot of them, you're going to risk damaging the probe. So the last thing that people ask me about the gel-free covers is, what about the clarity? If I'm going to use this and I don't have good visualization, then I'm defeating the purpose. On the left side of the screen, this is with gel. It is the same type of machine. One is in the left arm, one's in the right arm. And this is what you got. You see this here. This is you can see fascia bands. This is standard. This is with the gel free. You can see the same thing. Nice muscle fiber. You got a little cephalic over here. Here's a basilic. You're going to come over. Look at this nerve bundle right here with the gel free. That's very clear. And we don't have to worry about misidentification. Let me pull that over here. Yeah, here's a really nice picture of that nerve. So in my opinion, I look at this side by side. I don't see any difference in it. So we're about out of time, you guys. And just to give a quick summary, we need to standardize this procedure, which means there needs to be predetermined training requirements to this procedure. We need to be compliant with the techniques and the supplies that we use. There has to be oversight in this, because I'm telling you, when the cat's away, the mice will play, and people will slide into very bad habits. And then you've got this rogue program that's going astray. We need to have a competency for the insertion. It's not something that you just should say, hey, hey, you want to learn how to use this? Come here, I'll show you how to use it. And then that's it. And we really, it is our responsibility to know how effective our work is. So tracking first stick success rate is a great measure, but really what I'm concerned with even more is, do those devices last until they're discharged? The average length of stay is somewhere between 4 and 5 days in most hospitals, maybe 3.5 to 4 in a smaller hospital with less acuity patients. We have the technology and the knowledge and understanding of how to place a peripheral IV in the appropriate vein with appropriate length and last. So integrating ANTT with the identifying your key parts and key site, I believe is highly important. Probe covers, sterile probe covers for this, it's just a must. It's just a must. If you're going to use gel, you need to use gel or a sterile gel with this. There's too high a risk of contamination not to. But I know what people are going to say. Well, there's not any evidence that supports that we have to do this. Well, you know what? Let's not let common sense and good judgment get in the way of a bad decision. It just is really irritating, honestly. We need to make aware in your facilities contamination, because we have become numb to it, and it's become an accepted part of this procedure. It should not be. And infection preventionists are the people who really can jerk a knot in somebody's tail and say, listen, we got to do better. During the insertion, we've got to have less contamination. We want to, properly disinfect our probe. I'm not even getting into that, because low level, intermediate, high level disinfection, all that business, that's a big hot button right now. It has been somewhat settled, but still, that's not what this presentation is about. And honestly, in my opinion, we should consider using gel-free methods of insertion. So I think I finished right on time. This was 57 minutes of content. I hope this was informative. I hope this was impactful for you guys. It's something I am just so passionate about with peripheral IVs in general, specifically ultrasound guided peripheral IVs. I do a ton of precepting and instruction on this skill, and it's something we have to elevate. So thank you all. If you have any questions, I don't know if you can unmute and people can shout out. I'm going to stop sharing. Stop sharing. Stop sharing.
Hi, Matt. This is Chow. Thank you so much for a very good presentation. And we love how passionate you are around this topic and sharing your knowledge and expertise with us today. I just want to share with you that, we did receive several great positive feedbacks and comments in the chat. Your images and videos are very enlightening and great for teaching those who insert VADs today. So thank you for that. And there was one question that was sent to me in the chat. What do we do if we cannot find a vein that will accommodate a catheter?
Well, you have different options of insertion locations and different devices. So from and this is something that a question that I get often. Is what do we do? Well, you weigh out the risk benefits. If you're in ER, if you're in ICU, if you're in outpatient surgery, they all have different considerations that we need to consider, right? So you have to look at the risk of placing the device in a suboptimal insertion site in a suboptimal vein versus what you're getting and the risk of infiltration and what might come of that. So if your risk benefit says, I'm here for an outpatient, I'm here for an outpatient procedure, it's going to take 30 minutes, and this is all I've got a very small vein in a hand, you know what? That's not necessarily inappropriate for that setting. The risk benefit is going to say, okay, go ahead and place the device. If I have a critically ill patient that has a labile blood pressure, and I'm in the same situation, and I find a very tiny vein in a hand or a wrist, and I know that they're going to be receiving vesicants, it is not prudent to place that device. Matter of fact, that's what we have to stop doing. That's when you escalate, you go talk to your providers, you say, hey, there is nothing to stick. They're going to be receiving blah, 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 blah. The risk benefit set shows that this is a high risk patient with a complication, and we need a better device. So then you upgrade to a midline, a PICC line, a jugular line, a central line in the chest, a mid-thigh line. I do not recommend femoral lines, period, but mid-thigh is a much different thing. So you look for the other insertion sites in other devices, and so sometimes what you have to do is you have to step away from the patient and defer it to someone who has the skill to place a bigger, more invasive device. Did I say that? I mean, was that a reasonable answer?
Question came from Gwendolyn. So Gwendolyn, if you're still on the call, please feel free to unmute yourself.
I am still on the call. Can you guys hear me?
Yes.
Okay, yeah, that was a great answer. The only question I have to follow up to that answer is, what are your thoughts on vesicants through midlines? That's been a really hot topic where we're at right now.
A midline is a peripheral catheter, and the guidelines, the 2021 guidelines came out. I'm not happy about what they said about vesicants, because it allows for short infusions through peripheral catheters. I think that this idea, and I am in the minority with this, the rationale behind infusions, infiltrations with midlines versus a short peripheral catheter or a longer peripheral catheter is that they're going to have a much bigger infiltration. It's going to cause much greater damage, and the risk is much higher. I don't necessarily agree with that, because the tip of that catheter is in a much bigger vein. Can you have an extravasation in a midline? You certainly can. Is it bad? It can be, but having an infiltration in a wrist where the radial nerve in the radial artery runs up, and you're having tissue damage in a wrist and impairment in a hand because of the infiltration, I think is and what people don't understand with infiltrations is the more tissue you have around the vessel, the more ability that we have to uptake that medication. So if it's in an area of flexion with very little tissue there, our body can't uptake that medicine as quickly, and it sits there and burns and burns and burns. So I don't subscribe to it's worse to run vesicants through midline through a peripheral. I don't subscribe to that. I think it's equivalent. I can say I would support that it's equivalent. I don't want to do either one. We got some hands up here. Did that answer your question, Gwendolyn?
Yes, it did. Thank you.
Yeah, I am in the minority with vesicants through midlines. I can tell you that much. Looks like Julia Poschwitz has their hand up.
Yes, I am currently in the process of helping to build an educational platform at our organization in reference to ultrasound guided peripheral IVs. In your research, have you found using the gel within the probe, so the probe wand, gel, and then the probe cover covering it, does it show any significant issue? Because that is the avenue that we've been going currently based on the gel-free devices that you've been researching.
Gel inside the probe and then not using gel on the outside.
Exactly, yes.
Yeah, I mean, it's perfectly fine. You know, I mean, that you're not exposing the site to the gel. Is it necessary? It's not. It depends on what you're using, what products you're using, I would say, because the product that I have used, I don't need gel underneath of the probe. I haven't found that yet. But if that helps, and that's, that makes the visualization, I don't know what device your ultrasound.
Yeah, we have two different ultrasounds that we have presently at our organization, an older version and the newer version. You don't need the gel for because it is just superior technology. However, the older version.
Right. So I don't see an issue with having gel under the, inside the probe, at all. It's about at the site for me, trying to keep that much more clean and whatnot. Anybody else? Again, if you guys have any questions, I do a lot of this work. Matter of fact, I'm going to Michigan in one of the largest hospitals and working with the ultrasound program next week. So I come to Michigan pretty often, actually. And if there's anyone that needs any more help, if you need any, advisement, I can get you. I've done a lot of writing of education for this particular skill, so I can certainly bring you up to speed on current research, support articles. If you're writing a procedure, whatnot, I certainly would be happy to help with any of that. The infection prevention is how was this for you guys?
Matt, lots of positive feedback coming into the chat. What a great presentation. Okay. Everyone enjoys your videos, the pictures, and we are getting a lot of questions asking for you to share some of the sources where the videos and the pictures are coming from.
If I put my email in the chat, I'll put my phone number and email. How do you say how I do this?
And so Matt, I can always include it in the follow-up email as well, because I have your contact info. So I'll just throw that in there and let people know they can reach out to you if they have questions. Is that all right?
Please do. Please do.
Okay.
I'll just stick it in here right now. So there's my email address. And then Kelsey, I'll follow up with the email, and then whoops. And then, like I said, this is, I'm so passionate about this, you guys. I just
yeah, and we will follow up in an email with all participants today to access to the slides and the recording where they'll be posted. And I also did drop the evaluation link into the chat, so don't forget to complete that to obtain your CEs for today's session. Matt, you did get one invitation to feel free to swing by Sparrow's Hospital IV team in Lansing if you are in the area. So.
Okay. Oh, it looks like that's from Gwendolyn. Hey, Gwendolyn, you got my phone number now. Give me a call. I might stop by. I'll actually be coming through Lansing on my way home. So maybe we can connect. I'd love to meet your team.
I'm gonna hold you to that, because we'd love to meet you in person.
Sounds good.
Well, thank you again, everyone, for participating today. We did have great attendance, and thank you again, Matt. What a great presentation. We all enjoyed your passion, your enthusiasm, and some of our participants have said that it's very infectious in a very good way. So thank you for making the time to present to us today. And I hope everyone have a great Wednesday afternoon.
All right. Thanks, Chow. I appreciate it.
Thanks, Matt. Take care.
Bye-bye.